we'll never use. Unlike most training programs you attend where we hope you'll use what we're taught, this is one I hope you don't need to use what we teach you today, but it's information you ought to be familiar with. My name is Eric Ward. I've got about 30 years experience as a paramedic and a firefighter, both in the municipal side and in the wildland world. Have worked EMS and fire and law enforcement full-time over the last 30 years and done a variety of things. You might say I'm a jack of all trades, master of none, but I hope I've got some information that will be useful to you today. Okay. Stand by just a moment while we work on an audio issue to see if we can fix that. Okay, I'm going to go ahead and continue, and they may be doing some audio adjustment over the next minute or two of the presentation here. I do want to let you know as we get into this that this isn't a certification program, and it's not necessarily intended for medical professionals. This is designed to provide some basic level information for people who may need to provide first aid on a moment's notice. I do recommend, if you have the opportunity, that you get into a formal training program through the Red Cross or your local ambulance service or fire department or other folks that can help you to get some hands-on training and potentially some actual certification. But certainly what we're going to offer you today should be helpful in that regard. Also, a couple other just quick disclaimers, just because we're dealing with medical stuff here. The information we're going to provide is the most current that is available, but medical knowledge is continuously changing, and within a few years this information might be completely different. And of course, always anytime there's any kind of medical emergency, seek professional help if you have any doubt whatsoever about the outcome of the situation. Stuff we're going to talk about today, we actually presented this about 6 months or so ago at the Kansas Prescribed Fire Council and then adapted that to present this webinar today. I'm going to try to address some things either that have changed. Medical care is constantly changing, and a number of things that were traditionally taught in terms of first aid have since been found to be not accurate or not the best care available. And I'm also trying to identify things where you can actually make a difference. There's not much point in teaching something if you really can't be helpful anyway. So we're going to try to address some things where you might really be able to make a difference. I'm not necessarily presenting them in priority order, just in an order that kind of flows fairly logically. In the 30 years I've been in this business, much of what I was initially taught in my EMT and paramedic training has since been found to be outdated or inaccurate or useless or in some cases actually harmful. And like I say, it's evolving all the time, and so we're going to try to give you the most current knowledge available. Much of what we've learned in terms of caring for injured people is actually due to the military, regardless of political opinions on current military conflicts and so forth. Warfare has actually been one of our most productive sources of research in terms of injury care, because there's hardly any place you can get a large number of basically healthy people with bad injuries and compare the outcomes of different kinds of treatment. So much of our modern trauma care is directly thanks to the military. And in fact, even the birth of modern emergency medicine, dating back to the late 60s and early 70s, was because researchers identified that a person severely injured in the most modern of American cities had a much less chance of survival than a soldier with comparable injuries on the battlefield in Asia. And people felt like that was probably not a fair thing, and began to implement what we now know as modern emergency medicine based largely on battlefield care. So that's kind of the source of much of what we're going to be sharing with you today. One thing I highly recommend, even before you ever have to deal with an emergency, is have a plan. When government agencies conduct prescribed fire, many are required to have very extensive written plans that could arguably be called overkill in many cases. Private landowners aren't necessarily required to have written plans, or if they are, not nearly as extensively. But one thing you should always be looking at, whether it's a prescribed fire or even just a hunting trip or a camping trip with a family, is what am I going to do if something goes wrong? Who am I going to call if I have an emergency? What kind of help can I get? What kind of response time will that help have? How far am I from the nearest community? How do I get a hold of that help? Where is the nearest medical facility that can provide emergency care? All of that stuff is things you need to think about ahead of time, and not when somebody you care about is laying on the ground in pain, injured, and time might really matter. So have that plan in place ahead of time. Have a first aid kit. We'll talk about a few basic things you should have on hand as we go through this course, but have some sort of at least a basic first aid kit that can provide some boo-boo care and maybe some more extensive bandaging supplies if somebody has a serious injury. Always have that available if you're conducting fire operations or other types of potentially hazardous situations. And then again, as I mentioned, highly recommend taking a formal first aid and CPR course where you can have both hands-on training and some one-on-one interaction with an instructor. We can share a lot of material in a webinar, but of course it's never quite the same as actually sitting down with somebody and being able to practice some important skills. So with that, let's look at some of the types of things that you could encounter in a prescribed fire situation or other types of outdoor or wilderness or country-related activities. One of the first ones, of course, anytime we're talking about fire, there's always the potential for burns, and that's another area where our knowledge and our understanding of what's best has kind of changed through the years. There's some things you can do that are very helpful, and there's some things that are commonly done that are really not good for the injured person. For a burn to occur, basically the tissue has to be damaged either by heat or chemicals or radiation, which could be the form of solar radiation like a sunburn. We're going to concentrate on the heat-related thermal types of burns today because that's what you're going to encounter in a fire situation. For a thermal burn to occur, your skin or your soft tissues have to be heated up to the point that cell damage and tissue damage occurs, and that is a burn. If you think of a candle flame, you can pass your finger through that candle flame and not even feel any pain because your finger isn't there long enough to get hot enough to cause damage. But obviously, if you hold your finger in that flame for a second or two or three, it's going to heat your finger up to the point it becomes extremely painful and starts causing damage. Now think about if you move your finger away from that flame, it still hurts, right? And that flame has heated your finger tissue and cells up to the damage point, but when you move your finger away from the flame, it's still just as hot as it was in the flame, and it will slowly cool down, but as long as it's heated above that damage threshold, the damage will continue to occur for a period of time. So one of the very first things you want to do in any kind of significant burn is to cool it as quickly as you can. Get some cold water on it. It doesn't have to be sterile water, preferably not something with any chemicals in it if you use any kind of additives or foam when you burn or anything like that. But bottled drinking water, even cold coffee would be better than nothing just to quickly cool that tissue down to stop that burning process. Now that said, as soon as you get the burned area cooled down, stop. One of the biggest mistakes that's historically made in treating burns is we keep cooling it because it feels good. If you've got a serious burn, cold water on it is going to feel good. It's going to cause some pain relief. But especially with an extensive burn where a lot of skin is damaged, one of several very, very important functions of your skin is temperature control. And when you lose a lot of skin, you lose a lot of the ability to regulate that temperature, and then you complicate that by dumping buckets and buckets of water on this person, and very quickly you can chill them and actually put them into hypothermia. And an injured patient who gets chilled below normal body temperature, their body has a much harder time responding to that injury and recovering. So it's very important that we cool the burn quickly, but don't cool the rest of the person. Don't get them chilly. If they start feeling cold, you've got to stop that and get them warmed back up, which seems counterintuitive, especially if it happens on a hot day. But even on a very hot day outside, a burn patient can quickly get their body temperature to start dropping, and that can be very dangerous for them. The other thing I've got in big letters there, if you see the slide, is no goop. Now, if you have a small burn on, you burn your finger or something, and it's just something that doesn't require any medical attention, it just hurts, yeah, if you want to put some burn cream or something on it, it'll probably feel good, and there's probably no harm in that. If you have an extensive burn, putting some sort of cream or something on it will also feel good briefly. But what will happen is once that person gets medical attention, one of the very first things that medical provider is going to have to do is to scrub all that stuff off that you just put on the burn. And they may have thanked you when you first put it on and it felt better. They will be calling you very unkind things as that person is scrubbing that off of the burn in the hospital. So any burn that requires any kind of follow-up medical attention should not have any kind of goo or oil or salve or ointment or butter or anything like that put on it. It will feel good briefly, but it's going to be torture once they have to start scrubbing that off. So please, no kind of goo on a serious burn. The last couple things there, once you have cooled the burn off, cover it with a clean towel, a clean dressing, a clean handkerchief or something. If you have a fancy burn dressing, that's wonderful. But if you don't have, just cover it with something clean and dry that you have. And there again, it probably feel really good if whatever you put it on it is wet, but you're going to cause that chilling effect that we can't afford to have in a burn patient. So cover it with something dry. You can make it a little bit snug to help seal the air out, and that will help decrease the pain a little bit, and then get medical attention. If it's a real small burn, if you just kind of burn your finger or part of your arm or something, it may not be necessary to get medical attention. But any burn that's bigger than a 50-cent piece that has blistering to it, any significant burn involving the hands or the face or the feet or the genitalia should seek medical attention because you don't want any kind of long-term scarring or disability in those sort of areas. Any burn that involves the nose or the face where it might have gotten into the air passages definitely needs to get medical attention because that could lead to swelling. And any extensive burn that's bigger than, say, just your forearm should seek medical attention at the hospital or your local physician. And don't delay, because the earlier treatment can cause a better outcome than if you wait until you find out it's worse than you thought it was. Heart attack and stroke are another area that can be life-threatening, but can also make a big difference in how quickly you identify them and how quickly you respond. Both involve a circulatory problem that causes death to some of the cells. The heart, though it pumps all of your body's blood every minute or two through it, it still has to have an individual blood supply to every single cell of the heart to keep functioning. And the comparison I like to use is you could be a teller at a bank and you handle tens or hundreds of thousands of dollars in a day, but you still have to get your own paycheck at the end of the week to be able to buy groceries. And your heart cells are the same way. They handle all that blood going through, but they still have to have their own supply continuously. And if that supply is interrupted, heart cells start to die. A stroke is a similar event happening in your brain where every brain cell has to have blood supply constantly. And if for some reason either a blood vessel in your brain is blocked, so that blood can't get through to the brain cells, or sometimes the blood vessel will rupture, and so the blood flow to brain cells stops or is decreased. As soon as that happens, those brain cells start to die off. And time becomes very, very important because with both of these, depending on exactly what's going on, in many cases, a heart attack or a stroke now can be treated with medication and other treatments that can actually open up that blood flow quickly, stop the damage to the cells before it gets severe, and in some cases make it almost as if that heart attack or stroke had never happened if the treatment is done quickly and efficiently. So with a stroke, the main ways to identify a stroke are listed by that acronym there, FAST, and it'll involve three basic sets of signs or symptoms. One of the most common that happens in a lot of stroke patients is there will be some sort of a change in their facial movements. Part of the face may appear to be lifeless or dead. It may appear to kind of droop because the muscles on that side of the face aren't working properly. When a person smiles, it may appear lopsided. Now, some folks, like if I smile, I've got a little bit of a lopsided smile, but if you thought I was having a stroke, I'd be able to tell you, yeah, my smile's crooked, that's normal for me. If somebody's not normally lopsided when they smile and for some reason now they are, you need to be very concerned about that. The next one in that acronym, ARM, very common sign of a stroke is that one side of the body will stop working properly. It may not work at all. You may have one side of your body that's just limp, or it may be that it works, but they've lost a lot of control, or they've lost a lot of strength to it because that part of the brain that controls that side of their body isn't working properly. The simplest way to test for this, and you can do this even while you're listening here, close your eyes and hold your hands straight out in front of you for the next couple sentences I speak. And if a person's having a stroke, when they do that, one of their arms, either they won't be able to hold it up at all, or it may drift off to one side. So open your eyes, and if both your hands are straight out in front of you, you're probably fine. If during the time I was talking and your eyes were closed, one of your hands has drifted off to the side, or it's gone down, or whatever, you probably need to stop listening to the webinar and go to the hospital. But if you're checking somebody else and you do that, if they can't hold their hands out in front or they can't hold them together with their eyes closed, that's a pretty significant indication they may be having a stroke. And then the last one is speech, and this can happen 2 or 3 different ways. One can be that they can't speak at all and could beforehand, or their speech may become garbled or slurred, or they're speaking what sounds like words, but it's not words you've ever heard before. It's not the language they normally speak. Or it may be that they lose the ability to understand speech. They can talk to you, but it's obvious as you talk to them, they have no clue what you're talking about. So if you see any of those 3 symptoms, either facial changes or weakness on one side of the body or changes in their speech pattern, and it lasts for more than a minute or 2 or 3, these folks need to be in the emergency room and need to get help right away. With a heart attack, it's a similar type of situation. Blood flow is interrupted to part of the heart muscle, but of course your heart doesn't control other parts of your body like your brain does. What it will do if you're having damage done to your heart is it will usually hurt. There will usually be pain involved, and it can range anywhere from just a mild ache that almost feels like somebody just did too many push-ups, but they haven't, to a crushing, severe pain that they feel like they're being crushed in a vice, or they feel like there's an elephant standing on their chest or something like that. It can be anywhere in between that. It can be very severe. It can be very minor. But usually there's going to be pain involved. Pardon me. I will say that women more often will have a heart attack without pain than men will. Most men, if they have a heart attack, will have pain with it. A fair amount of women, if it's a heart attack, will not necessarily have any traditional chest pain with it, which is one of the reasons heart attacks among women have often been mixed diagnosed, because it just doesn't act like a heart attack. There's no chest pain. The other things that can go along with that, there can be just a general feeling of not being well. There can be shortness of breath. A person may just have trouble catching their breath or feels like they can't get a deep breath. A lot of times that pain in their chest may go through to their back. It almost feels like a back injury. It may go into one arm or one shoulder, more commonly on the left side, but not always. I've had heart attack patients before that their main complaint was that their left shoulder and arm felt like they'd injured it, like maybe they'd lifted too many weights or they'd sprained their shoulder or something, except when you get to checking, they haven't done anything that would injure their shoulder. And you start looking further and find out that that's basically the pain from the heart attack. They might get very sweaty, they might have a pale color, or in some cases they'll look really bad. They'll be very pale, very sweaty, and you just look at them and say, there's something wrong with this guy. Other cases, they'll be pretty much fine except for that dull ache in their chest. If any of these happen, and again, if it lasts for more than 2 or 3 minutes, or if it happens and goes away and comes back and goes away and comes back, they need to be in the hospital getting evaluated. It could be other things, but if it is a heart attack, time matters. And with both heart attack and stroke, getting definitive treatment with the medication or with surgical intervention within the first hour or 2 dramatically increases the likelihood of success. And for every few minutes that you delay it, the chance of curing the problem goes down rather quickly. So time is very, very important. In most cases, if there's any chance of a heart attack or a stroke, I would strongly recommend call 911 and have an ambulance transport them to the hospital. They're better prepared to assess whether that's really what's going on. If the patient deteriorates badly on the way in, they're better prepared to deal with it than if you're taking them in the car and they get worse. And they can also coordinate ahead of time with the hospital to have advanced treatment standing by as soon as they get there that you just can't do if you're taking them in the car. At the same time, I recognize there are going to be places in rural Kansas where the time for you to drive to the hospital is going to be less than what it's going to take you to get an ambulance. So you have to use good judgment in that, but most of the time you're going to be best off having professional help transport that person. The last section on this, CPR, again, I would recommend finding a formal CPR course through the Red Cross or the American Heart Association where you can do some actual hands-on practice and stuff. It used to be when we taught CPR that we said, you know what, if you haven't had really good quality formal training, you should never do it because bad CPR is worse than no CPR. I don't know whatever made us think that was the case, but any CPR is better than no CPR. If a person needs CPR because their heart has quit, they're dying by the second. And every second CPR is delayed decreases their chance of survival. Without CPR, they have 0 chance of survival once their heart quits. With CPR, if you do really, really bad CPR, they've still got a 0% chance of survival. So nothing is any worse than no CPR. If you do good CPR, they've got a slim chance of survival. So if they quit breathing, if there's no moving, they're not responding to anything, and there's no sign they're breathing, start CPR. The other thing that is a big change is they are much less picky on how perfect your hand position is. They're not even requiring for lay rescuers anymore that you breathe for the person. They've even found for professional rescuers that hard, fast compressions in the middle of the chest are much more important than doing rescue breaths. And that totally goes against everything we used to think we knew. But hard, fast compressions right in the middle of the chest, compressing their chest almost half the thickness of their chest if you can, is going to be effective. If anything will work, that's what's going to help. The proper rate is about 100 times a minute. The really easy way to remember that is that's about an average disco beat. So if you think of, depending on how positive you are, the old disco song, Another One Bites the Dust, that's a little bit morbid for somebody who needs CPR, but the speed of that is just about right. The other one that's maybe a little more positive outlook is the old song, Staying Alive. If you can do CPR to the beat of Staying Alive, you're at the perfect beat for CPR. So you don't have to get real hung up on how perfect you are. Just sing Staying Alive in your head and do compressions at that rate and get help there as quickly as you can. I want to go into heat illnesses. These are probably not nearly as critical as a heart attack or a stroke, but you're much more likely to see them. In fact, probably if you do hard work outside at all, you've probably had some mild heat illness at some point. But I want to talk a little bit about some things that might help in recognizing it. It's a very predictable occurrence in the kind of situations we're going to do fire in. We typically do it on hot days. A lot of times it's often fairly dry. A lot of times what is supposed to be an hour or 2 or 3 project stretches into many hours of work. And it's very easy to get into a heat illness situation. Being physically fit and staying very well hydrated both help a lot, but they don't completely prevent it. A very, very fit, very well hydrated person exerting in the heat can still develop heat illness. So it's not just a sign of being out of shape or dehydrated. But that said, it is important and helpful if you're going to be working in a hot environment to drink lots of water, and don't just wait till you get thirsty. Start it before you ever get out there. If you're going out on a hot day and you're going to be doing a lot of walking and working, start drinking an hour before you ever head out. Now, when I say drinking a lot, I am talking about water here. Alcohol and fire don't mix to start with, and from a hydration standpoint, alcohol will dehydrate you. They have decided that caffeine is not nearly as much of a problem as they once thought it was. If you normally drink caffeine, whether you get your coffee or your Mountain Dew or whatever, it's fine to do that, but don't really consider that being hydrated. It's not harmful, but it really doesn't help a lot. Lots of water and a little bit of sports drink. 2 or 3 or 4 drinks of water and then have a sports drink is probably about right. You don't need lots and lots of Gatorade or Powerade or whatever you like. But every few drinks probably ought to be a sports drink just to replace some of those salts and stuff that are being lost. Signs and symptoms of heat illness typically start gently. You're not just going to probably be out there working hard and everything's perfect, and all of a sudden somebody just collapses. There'll usually be some progression. You kind of start to not feel that great. You may start feeling fatigued more than what the amount of work you're doing really justifies. You're thinking, man, I shouldn't be this wiped out for no more than I've done today. The person may start feeling nauseated. They might have a headache. They might get a little bit dizzy. Any of that stuff is probably an indication, if you're in a hot environment, of some heat illness starting to develop. At that level of symptoms, it's really not a medical crisis, but it is a sign that you need to deal with it and not let it get any worse. So at that level, that person should be removed from the heat, at a minimum put into the shade. Better yet would be an air-conditioned vehicle or an air-conditioned building. Get some air moving on them. Get them some sports drink and some water to start sipping on. Don't just gulp, gulp, gulp it, but they should be sipping pretty steadily to get some more fluids into them. And once a person starts to feel ill from the heat, they need to be out of the heat for a day or two. This isn't somebody you want to just have them kick back for 15 minutes and then get back to work. They really need to get out of the heat and give their body a chance to recover and to rehydrate and kind of get its equilibrium again. But at this level, as long as the person does get to feeling better after they get out of the heat and get some fluids, probably doesn't require medical attention unless they have other medical problems. However, if they get to the point where their mental status starts to change, that could mean they start getting confused, they start feeling faint, they pass out, they get lethargic. Anything like that is a sign that the brain is having problems. And once the brain is affected, it's time to get that person to professional medical help, even if you get them out of the heat and they start to feel better. Once a person's had any change in their level of consciousness or their medical status, you have to consider it a medical emergency now. Definitely get them out of the heat. Definitely start cooling them down. Again, we don't want to make them start shivering because we cool them so far, but some cool rags on their head, cool packs around their neck, in their armpits, and their groin where major blood vessels flow, cool rags around their head, fans, air conditioners, all of that can be helpful. And start getting that person cooled down. If they're awake enough to drink without choking on it, it's good to have them start sipping some fluids as long as they can keep them down. If the fluids are bouncing, there's no point in shoving more down them. But if they can drink comfortably, have them be drinking, have them be getting rehydrated, and then get them to professional help. If they lose consciousness, get 911 involved, get them in an ambulance to the hospital. If they start feeling better, then it's probably okay to drive them into the clinic or take them to see their doctor or whatever, but they need doctors' follow-up before they get back to working hard. At a minimum, they're going to need several days out of the heat to recover. The next one I want to talk about, and this is one that is definitely a situation where the military has contributed in a big way to better understanding of how we can care for people, is severe bleeding. Many years ago when I was a Boy Scout, they called this one of the hurry cases because it's one where time really matters. Many of these things, time is not super critical. I mentioned with heart attack and stroke that minutes count. In severe bleeding, this is a case where minutes count. You have a finite amount of blood in your body, and if it's leaking out unstopped, you'll eventually run out. And actually, before you run out, things get really ugly. So any case of severe bleeding needs to be stopped. Some of the things that we used to recommend, we have found are really pretty useless in terms of stopping bleeding. And it used to be until fairly recently, the last really few years, that the concept of using a tourniquet became popular again. I taught for many years and fully believed, as most of my coworkers did, that a tourniquet was a barbaric device that if you used it, it proved you'd failed at everything else and probably weren't doing your job right, and that there's probably no reason anybody should ever need to use one. Well, the military figured, oh, the other thing we believed on a tourniquet is if you put one on and cut off circulation to somebody's arm or leg, they would probably lose that arm or leg as a result of the lost circulation. Well, thank you to the experience of the military, who learned that many of the savable battlefield casualties that wound up expiring in combat were due to bleeding to death from extremity wounds. And they said, you know, that's just not right, let's fix that. And the military started using tourniquets pretty extensively, Of course, their situation is different than most of us live in terms of the kinds of injuries they deal with. But in the ag world and industrial world, the potential for devastating extremity wounds is certainly there, more so than for probably the general population in the country. But severe bleeding is fairly easily controlled. The other thing they learned is that with modern medicine, you can have that person to definitive medical care within an hour or two that can fix the problem, restore the circulation of that extremity long before they're in danger of losing an arm or a leg from the tourniquet. So we really shouldn't be afraid of it. So if you have severe bleeding, the first step, which will almost always work, is direct pressure. Put a gauze pad, a bandage, a paper towel, a rolled up t-shirt, or whatever you got, put it right on the wound and hold it tight. Very simple, very low tech. It takes absolutely no skill or practice to do it. And it's no different than what you do to patch any other leaking hole in any other kind of object. If you've ever poked a hole in the bottom of your coffee cup while you're fiddling with it or something, you put direct pressure on it. You put your finger or your hand over it and held it and stop the leaking. It's really the same thing with the wound. Put the pressure on it, put a patch on it, and hold it tight. Most things that you'll probably ever see in your life, and most things I have seen in full-time emergency medicine, that fixed it. There'll be very few exceptions. But if you do encounter one of those exceptions where direct pressure doesn't stop the bleeding right away, then it's time to move on to a tourniquet. And you'll probably save a life if you do. There's a couple of options. The simplest, if you have access to it, is to use a commercially manufactured tourniquet. There are several brands available. They usually retail in the neighborhood of 30 or 40 bucks, which seems like quite a bit. But if you're buying supplies for a first aid kit, it might be worth considering. You can pick up used, or not used, but surplus military ones off of eBay and Amazon for quite a bit less than that. The one in the picture that you're seeing is called the Combat Application Tourniquet, or CAT, designed for military use. But all that you have to do to apply this thing, there's a buckle, and in the upper left picture you see a buckle that the person has threaded the nylon strap through. Pull it as snug as you can get it. Oops, sorry, didn't mean to back up on you there. Thread it through that strap, pull it tight, and then there's a windlass there, that stick that goes across. You start twisting it. And you ask, how far do you twist it? You twist it until the bleeding stops. It will compress the extremity, slow or stop the blood flow into that extremity, and the bleeding will stop. Once you get that bleeding stopped, of course, you don't want to let go of it. So there's actually those little C-shaped clips that you see on the upper part of that photo. And on the right, it shows that windlass has been hooked under the C-clip, and there's a little Velcro piece that just goes over the top to hold it in place so it can't unwind itself and allow bleeding to start again. It's wonderful if you have one of those. If you don't have those, it's still very easy to create a tourniquet. The bottom picture is just a hand-drawn sketch of a basic crude tourniquet. You take a piece of bandage material out of your first aid kit, or a bandana, or a handkerchief folded into a little bandana type of configuration, a piece of strap, or whatever. The only thing we would not recommend would be rope or cord or wire or something like that, because that will cause severe tissue damage. But any kind of inch or 2 or 3 wide cloth band, put it on there tight, stick a stick through it, or a screwdriver, or a pair of pliers, or whatever you got handy that's a little bit sturdy, stick it through a layer or 2 of that band, and again, just like before, twist it until the bleeding stops. And then once it stops, just put another wrap of something around it to hold that in place so it doesn't unwind. Very simple, very low tech, doesn't require a huge amount of practice, and doesn't require fancy specialized equipment. What it does do is potentially stop severe bleeding and save somebody's life. If you do have to put a tourniquet on it, obviously this is a situation that requires emergency medical care. You wouldn't be putting a tourniquet on something you're going to just send home to get better. They need to be in the hospital, and you need to make sure that whoever receives that patient, whether it's the ambulance or the emergency department, that they know right away that a tourniquet's been applied. They may eventually take it off if the bleeding is well controlled. They may do other things first, but if it's that bad, you've probably saved a life by doing that. And we now know you've probably done no harm in applying it like we used to think would happen. Minor wound care, this is one you'll definitely do over the course of your life. Certainly if you've ever been parents or grandparents, you've probably done it. Most of you at some point, I'm sure, have cut something that you had to fix. And it's also one where we learn a little bit about what's good and what's not so good. Obviously, if there's severe bleeding, go back to what we were just talking about. We don't care about the wound care so much. Stop the bleeding and get them to the hospital. If it's not a severe bleeding situation, it's just your normal cut and scrape that we all get every day, there's really only about 2 steps to it. Wash it and bandage it. Soap and water is great. If you don't have soap and water, clean water from a drinking water bottle or something like that, just to kind of flush it out and get any crud out of it that might be there, and a basic bandage. What's not recommended anymore, and we used to think was, the thing to do, was put disinfectant stuff on it, whether you did hydrogen peroxide or iodine or any of the other stuff that used to be available. Well, still is. A lot of people still do it, but what they found is if you put disinfectant stuff like peroxide on a wound, it does a pretty decent job of killing the germs that are there. Whatever germs it comes in contact with, it will probably kill. The problem is, of course, it goes away very quickly, and in the process of applying it to a wound, it creates a lot of tissue irritation. So you kill off the germs that are there right now, but as soon as the stuff evaporates or goes away, now you have really irritated tissue, which is much more receptive to the next batch of germs that come along, and you've actually got a bigger chance of infection than you had before. So if you just wash it with soap and water, keep it clean and dry, put a bandage on it, you've done the best thing you can do for it. Keep all the other stuff out of the way. Don't put it on any kind of wound. You'll just make matters worse probably. And a lot of them hurt, so why do something that hurts if it's not going to make it better? And of course, if in doubt, seek medical care, see your doctor, go to the emergency department. If in doubt on stitches, it never hurts to get checked. I will tell you, most of the time if you ask if stitches are needed, they're going to tell you yeah, because you're there. But if you have any doubt, it's probably better to get a couple of them than to leave something gaping open and have problems in the long run. Certainly any significant wound on your face or places where a scar might be a problem, you probably want to get looked at. Anything that's going to gape open, or if it's on a joint or something where every time you bend it's going to tear it back open, probably best to just err on the side of getting some stitches in it. And of course, if you haven't had a current tetanus booster, it's a good idea to get those. I would recommend anybody that works in fire or agriculture or industry or anything like that where you got maybe a bigger than average chance of getting cut, make sure your tetanus booster is up to date. Make sure you got one about every 5 years. See what your doctor recommends and go with their advice, but stay on top of that. And that way, if you do get a wound, you don't have to worry about it. You just know you're covered already. Seizures. This is a topic, or not a topic, but a emergency that can be very frightening to people if they see it and they're not familiar with it. So what is a seizure? The typical assumption is that a seizure is when a person falls to the floor and shakes and has convulsions and stuff, and it can be. That can be a sign of a seizure. It can be as simple as what they call absent seizures, where a person basically just checks out for a few moments. They're conscious, they don't fall over, but they're not there. And I'm not talking about the spacing out that most of us do this time of day after a long day at work, but they're actually not responding. You can walk in and try to talk to them and they're not there. And then they're back. It can be a simple twitching of an extremity that takes place for a while, depending on the kind of seizures a person has. Or it can be as much as a full body seizure where they do fall to the floor and they have convulsions and their arms and legs contract and expand and they foam with the mouth and they make strange animal sounds and they may become incontinent and lose control of their bodily functions. That's when it gets really alarming for people that don't know what's going on. But the reality is that's not the person's problem. You look at that and see all this stuff going on, and it looks scary and it sounds strange, and people think that's the problem, but a seizure is actually happening in the person's brain. All the stuff you see in their body or their arms or legs or whatever is just an indication of what's happening in the brain. And if you think of the brain as a computer, you're basically a computer-operated organism. Your brain is the most complex computer ever made, and like any other computer, it can once in a while have a hiccup and something goes wrong. Most people never experience it, or the worst you ever experience might be that you notice, something twitches a little bit once in a while. But a person with a seizure disorder may have this happen with some regularity. It can be a result of a disorder like epilepsy or something like that. It can also be a result of other kinds of brain problems, brain injuries, brain tumors, all kinds of things. For a person who is known to have epilepsy, this may be part of their normal life. I've had several patients I've dealt with through the years that had seizures periodically. It was normal for them. The only time we would get called as the paramedics would be if they did it in a public place and people didn't know about it. And we'd get called and we'd get there and say, oh, yeah, we know this guy. He does this. He's fine. We know he doesn't want our help, so we comfort them and stick around until they got to feeling better, and then they never wanted to go. If it's the first time somebody's had a seizure, it's very, very important to get medical attention and get evaluated to find out why it's going on, because it could be a sign of something very, very serious. But if a person has a seizure like that, what should you do and what should you not do? And I'm going to start with what should you not do. And that's going to be probably everything you've ever learned. Don't try to hold them down. Definitely don't try to shove anything into their mouth. I've seen several seizure patients who were disfigured and probably wound up with scars for life because somebody had heard that you need to get a spoon in their mouth because they might swallow their tongue. That's been taught for decades. They're going to swallow their tongue. They're going to swallow their tongue. Well, next time you're brushing your teeth, look in your mirror and lift your tongue up, and you'll notice it's attached in the front of your mouth. It's physically impossible to swallow your tongue. It's hooked on to prevent that from happening. What can happen if a person is unconscious and they're laying on their back is the tongue will kind of fall back and block the back of their throat a little bit so air doesn't get in and out. Very possible for that to happen during a seizure, but nothing you're going to do is going to change that. They're going to have the seizure until they're done. And short of advanced medication, there's nothing you can do that will change that fact. So don't try. The best thing you can do if somebody's having a seizure is to gently restrain them, and I don't mean hold their arms and legs down, because they're going to writhe and flop and do whatever they're going to do, but keep them from running into something. Don't let them whack their head on a table leg. Don't let them fall down a flight of stairs. Protect them from doing something harmful to themselves, and protect them from the good intentioned bystanders around who still think they need to shove a spoon in their mouth. Let them do what they're going to do. Just protect them, and then protect their dignity, because especially if it's not happened before, or if they're in public and people are scared and panicking and freaking out because this person's doing this, they will eventually recover, and it may be very embarrassing to them. It may be very painful for them. They may be embarrassed if they've wet themselves or done other things. So try to protect their privacy and their dignity. Keep people quiet and calm around them, and let them do their recovery. Now again, if you don't know for a fact that this is a normal part of their life, call 911 and get professional medical help for them. But whether or not it is, protect them from anybody trying to do good and actually harming them. The other thing is, once the seizure ends, just like your computer, the brain will have to reboot. And just like your computer, it's going to take a little while. So it can be anywhere from seconds to quite a few minutes, like 30 or 40 minutes sometime, where they will go through a period where they very slowly start to come around. They wake up, but they're confused. They don't know what's going on, and then gradually it progresses to they're awake and they're as normal as you or me. So recognize that's going to happen, and protect them and help keep them safe during that time. The last slide I want to talk briefly about before we give a chance for questions is animal and insect issues. And there's several things that you could run into. Of course, there's always the mosquitoes and the chiggers and that kind of stuff that can be a real irritation when you're out working in the woods, but those really don't require any kind of first aid or emergency care other than smack them and use some bug spray to try to prevent them. But some issues that can be more serious, snake bites are a concern. Pretty rare in Kansas, and I will say that most of the time if somebody gets bit by a snake, it's because they were doing something dumb, like trying to pick it up or trying to poke it with a stick or whatever. But it's also possible that you're out minding your own business and you step over a log and there's an unhappy snake on the other side and they bite your ankle. If it's at all possible to identify the snake, it's very helpful to do that. If it's a non-poisonous snake, you don't need to treat it any different than you would any other wound. Wash it, dress it, and just watch it for indications later of infection or something. If it's a poisonous snake, or you think it is, then absolutely you want to get medical attention right away. Traditional treatment for snake bites is another thing that has been shown to be more harmful than helpful. Cutting the wounds to try to get venom out only increases the size of the wound, so the venom actually absorbs easier because you have more surface area. And what does your heart rate do if you're in pain? If somebody's carving on you with a knife, what's your heart rate going to do? It's going to go up, right? And when your heart rate goes up, you circulate the poison faster. We thought at one time ice would help because it would decrease circulation in the area. It actually causes tissue damage and the poison absorbs better. We put tourniquets on at one time thinking we slow down the circulation. That really doesn't help for a snake bite. Great for severe bleeding, useless for a snake bite. We tried sucking the poison out. You can't suck poison out through a snake bite. It's useless. So what can you do? Very little, actually, except get them to the hospital. The one thing you can do that's very helpful is keep the patient very still, keep them calm, and keep the affected extremity as still as you can. What you want to do is minimize circulation. Keep their heart rate from getting up. Keep that arm or leg from being used, which then circulates more blood and stuff through the extremity. Slow down the circulation of that poison into the system and get them to the hospital. And I would highly suggest on the getting to the hospital part, call ahead if you're taking them yourself and let them know we're bringing in somebody that's been bit by a timber rattlesnake or they've been bit by a copperhead or whatever. The anti-venom for treating snake bites is very expensive. It expires and it is very, very rarely used. So many hospitals do not have it available or don't have the specific treatment for the snake that you've been bitten by, and they're going to have to make arrangements to get some flown in or brought in from someplace that has it or to get you to someplace that has it. So if you can call ahead and get that process started, it will help. The other thing, and I'm not trying to speak ill of anybody, but I think it's probably pretty safe to say that most hospitals you're going to go to, nobody there has ever treated a significant poisonous snake bite. It just doesn't happen very often in Kansas. So to be fair to them, give them a minute to look it up or review it or pull out the medical book and look and say, oh my gosh, rattlesnake bite. I remember that from medical school 30 years ago. Give them a chance to get ready for you. Ticks, annoying little boogers. They can carry disease. Several diseases like Lyme disease and Rocky Mountain spotted fever can be pretty significant. If you get a tick, of course, if it's just crawling on you, squish it. That's all you got to do. They are hard to squish. You may need to use pliers or something. You can't just step on it, but just kill a little thing and be done with it. Once it bites you, it actually kind of burrows into your skin, bites into you, and hangs on. And you want to get it out of there because the longer it's there, the bigger a chance it has of transmitting infection, besides the fact it's just really disgusting. So if you get bit, they make several commercial tick removal tools, but you can do just as good a job with a pair of tweezers or needle nose pliers or something. Grab it. Don't squeeze any harder than you have to, because if it's already sucked some stuff in, you really don't want to squeeze it back into your skin. But grab it just firm enough, give it a nice, gentle pull, and usually it will let go and you can just pull it out. If you give it a quick yank, it may hang on and you actually pull a little piece of you out with it. So give it a slow, gentle pull and you usually get rid of the thing. Not a bad idea if you can put it in some alcohol and save it. This is a case where it's probably not a bad idea to put a little alcohol right on the spot just in case there were some germs it was trying to transmit. And then make at least a mental note of where you got bit and when it happened. Because if you do start developing signs of infection at the site, you start getting a lot of redness and swelling or something, you definitely want to seek medical attention. And the other thing is if you've had a tick bite and within the next several weeks or a month or two afterwards you start developing what seems like the flu, it's probably best that you see your doctor and let them know, hey, I feel like I got the flu, but I did get bit by a tick on my left arm 6 weeks ago. And they can test you for Lyme's disease and stuff. That's a very treatable disease if they identify it, but if you just keep putting it off thinking you got the flu for weeks on end, it can cause a lot more problems. So if in doubt and if you get sick after a tick bite, get checked for it. And then the last one is insect stings. Bees, wasps, some types of ants can sting, and depending on the kind of insect that stings you, it may leave a stinger in you, which will look like a little tiny sliver with a little tiny clear sac attached to it. And that's actually a little sac of venom. It's got some muscles on that sac that will spasm and continue to inject venom over a period of several minutes. Other types of stinging insects will keep their stinger, so they can sting you over and over, but once they move on, the stinging is done. All you have is whatever they stuck in you the first time. If there is a stinger there, scrape it off with something. Either gently scrape it off with the edge of a knife or the edge of a credit card or a fingernail or something. It's recommended to scrape it rather than to try to pick it out with tweezers, because if you use tweezers, you could squeeze that little venom sac and actually squeeze in some more. For most people, an insect sting is very painful, but nothing worse than that. It's going to hurt for a while. Within minutes to hours, the pain will dissipate and you'll be fine. There are people who are severely allergic to bee stings, and in some cases allergic enough that they could die within minutes of one. If there's any sign of allergic reaction, you've got to get medical help right away. If you know you're allergic to insect stings and you work in the field, you should definitely carry your prescription medication with you at all times and make sure it's current. Signs of allergic reaction can include itchy, watery eyes, runny nose, itchy skin, hives, which are often raised welts and pink spots that develop on your skin. All of those can be a sign of allergic reaction, but probably not life-threatening. If the person starts to feel like their mouth or their throat is swelling and getting tight and it's hard to breathe, that can be life-threatening. And that's somebody that definitely needs to be treated with their prescription EpiPen if they have one. And whether or not they do, they need to be getting to the hospital right away. So with that, I've covered the material that I wanted to cover here. But I would be welcome to answer some questions during the remaining minutes that we have. If you have any, you'd like to type them in, Carol will relay them to me here, and we will try to answer them as best we can.
Thank you, Eric. That was a great presentation. We do have time to take a few questions, so I will be looking for those to be typed in. Okay, we have a question here from Jim. Chigger or other irritating bites, the patient should not scratch the bites as it can result in opportunistic infections. I got a staph infection one time because of this. Do you have any comment, Eric?
That is true. Anytime you get any kind of bite where you start scratching them, if you disrupt the skin, then there's the potential for introducing infection there. Now, like a lot of advice, that's much easier said than done when you got that maddening, itchy bite that, man, you just really want to scratch it. But if you can avoid it, certainly do. And either way, keep it, like any other injury, keep it clean and dry and try to prevent something that might cause infection in that area.
Okay, the next question is from Kyle. Does the application of an EpiPen vary by state or state laws?
An EpiPen is a prescription drug, so depending on where you're located, if the prescription is prescribed to you, there is no problem anywhere of you using it because it's prescribed medication, just like if you take a heart pill or an asthma medication. For a layperson, if you're using an EpiPen that is prescribed for that person and they're having problems, there should be no problems with you delivering it. It does get a little sticky for medical professionals who operate under specific protocols and guidelines. In most states, if it's the patient's own medication, any EMT or paramedic should be able to use that now. But as long as you're giving something that's prescribed for that person, you should be fine. The one place you might be in trouble would be if it's your EpiPen prescribed to you and you decide to use it on somebody else, because you're basically, it'd be the same as you deciding to give somebody else your heart pill. It's not a good idea, except that there is so little that could go wrong with using an EpiPen, and it has so much potential to be life-saving that I would feel it would be very, very unlikely anybody would ever try to make an issue of it on that. It's not a drug that's going to be abused, and it's not one, at the doses it's being given, it's not going to have any real serious complications to worry about. So if in doubt, and if they're having an allergic reaction and you've got one, I'd say give it.
Okay. Tim is asking, how about using Benadryl for bee stings?
Benadryl can be beneficial because it's a histamine blocker, and the serious complications of a bee sting are because of a histamine-type reaction. That's what causes the swelling and a lot of the other stuff that is really bad. The problem is that any kind of oral medication is going to take many, many minutes to take effect. anywhere from 10 to 30 or 40 minutes to take effect. If it's a severe allergic reaction, a person could be dead in 2 or 3. So it's certainly not bad to take it or to use it, but it's not going to take an oral Benadryl, at least like a Benadryl pill, is not going to address the emergency crisis situation. It'll help you down the road, but it's not going to help in that first few minutes while their airway's swelling. So that's where the EpiPen will work very quickly, within seconds to a minute or two, and getting professional help that can provide Benadryl through IVs and stuff as well can be beneficial.
Okay, it looked like we had a couple people writing, and until they hit the send button, I'll ask a question. What should be in your first aid kit on the fire line?
Okay, good question. I would say at a minimum, some basic bandaging stuff, ranging from Band-Aids to some gauze pads and roller bandages. I will say if you buy a commercial first aid kit, a lot of them you spend way more money than they're worth. They'll have a box of 4-inch gauze pads and a box of 3-inch gauze pads and a box of 2-inch gauze pads. I learned a long time ago, anything you can put a 2-inch gauze pad on, you can put a 4-inch gauze pad on. So just buy the big ones and be done. You don't need each size. If you can get a commercial tourniquet, it's a really good idea to have available. Pair of scissors for cutting clothes. Pretty good idea to have a pair of gloves so you don't have to deal with somebody's blood if you don't feel comfortable with that. Having some basic over-the-counter stuff like aspirin and Benadryl can be helpful. For the layperson, I'd say that's a pretty good start. And of course, you can get as fancy and elaborate from there as you want to. You can spend hundreds of dollars if you wanted to. And any kind of basic container, a tackle box, a toolbox, a big Ziploc bag can make a decent first aid kit if it'll hold the stuff you got.
Okay, Bob asked, will fire cause sunburn?
Fire will not cause sunburn as such. What it could cause would be a radiant heat burn, which, you're really talking pretty much a technicality there on the difference. Whether it's a thermal burn or a sunburn, it's still a burn, and you can still treat it about the same way. But it would really be the radiant heat that would be causing a burn there if you don't have direct flame contact. It would look and feel like a sunburn, and really operationally it doesn't matter. It's going to hurt, and cooling it off and keeping it clean and dry is going to fix it. So,
could you advance this green one? Keep going. The next one.
Oh.
Okay. We've got a question here from Josh about burning in wooded environments. And can you talk a little bit about blunt force injuries such as falling branches and other large things falling?
Okay. Yeah, and that could get into many things. I mean, you could be dealing there with anything from fractures to internal organ injuries to head injuries to just a simple bruise. And I actually was going to mention in the opening comments that we can't possibly cover everything you ought to know, because that would be many hours. But the basics, if it's a broken bone, would be try to avoid moving the broken bone. If you have the capability to apply some sort of a splint to keep the bone ends from moving and keep that arm or leg from moving, that would be wonderful. If not, I would suggest getting professional help involved to move the person without a lot of pain and tissue damage. Internal injuries, if somebody's got an internal head injury or an internal organ damage through blunt trauma, there's really going to be very little at the first aid level that you can do other than recognize that as an injury and get professional help, because even as a paramedic, there's pretty much nothing that can be done to help a head injury or a internal bleeding damaged
bones.
We can splint broken bones. Of course, there's pain medication and stuff like that. But the real solution for any of those types of injuries is going to be surgery, and they're going to have professional help in an ER to get treated if it's bad. If it's just bruises and stuff like that, then of course some ice and pain medicine will usually take care of that.
Okay. It says, what about eye injuries?
Eye injuries. Best thing to do with eye injuries is to prevent them by having safety glasses or something like that, but we also recognize that many of us don't wear them as often as we ought to. If it's a burn to the eye or any kind of foreign object in the eye or any kind of chemical in the eye, the best treatment is lots and lots of water. And this would be a case where the don't use too much water wouldn't apply. If there's any kind of a chemical or thermal injury to the eye, keep running water on it until you run out of water. If it's a physical damage to the eye, something's been poked in or it's been struck by something, then the best thing you can do is to cover it and cover the other eye. Because if one eye moves, the other eye moves. So if you cover just the injured eye and they're still trying to look around at their other eye, they're going to be doing more damage. So you really have to cover both of them. And eyes are so important that if you've got anything with an eye, get to an eye professional. There's too much at stake. You know, if your little finger quits working, you can get by with mine. If your eyes quit working, there just isn't a way to get around it. So take the time to see an eye professional if there's any doubt about your eyes at all.
Okay. I know you said no goop, but what about, this is from Andrew, you said no goop, but what about the medicated gauze made specifically for burns?
Opinions are going to vary on that. I've talked to, in the past, and it's been a while since I've asked this question of them, but I have talked in the past to some of the burn center folks, and they don't even like the ones that are specifically made for burns because of the fact that it still has to be scrubbed off. There are some purely water-based things that may be okay because they can be pretty much rinsed off and not require scrubbing, but there's really just not much benefit to using them. My personal feeling, and if in doubt, I would check with your physician or your local EMS provider to see what they recommend, but my personal feeling is there's not enough benefit to justify it. When you can cool it with water and cover it with a dry dressing, you don't have anything that has to be scrubbed off, and you're not going to make them cold, so it's probably just not worth the potential hassle and trouble. And water and dry dressings don't have to expire, so you don't have to keep buying new ones for your kid.
Okay, it looks like we have one last question here for Eric. It's actually more of a comment, and they're requesting, Chris is requesting if we could have a list of a first aid kit contents beyond the 20-man kits we get from GSA. Well, those of us that don't get the 20-man kit from GSA, we'll start from even more basic than that. So you want to, would that be possible?
I could put something together. I think to a large extent it's going to depend on what specific training you have and what kind of hazards you deal with, and that's one of the reasons I'm always a little leery of any pre-made first aid kit, because it will typically have, like I say, 5 different sizes of bandages when the large size could cover anything, so you really don't need 5 different sizes. Or it'll have stuff that people aren't trained to use, or it won't have stuff you are trained to use. I could certainly put together a basic list, but what I would recommend as a starting point would be, especially if you take a formal first aid class, is just make notes as you go of everything they teach you how to use. If they teach you how to make a sling out of a triangular bandage, it would be great to have one in your kit. If you don't know how to make a sling out of one, it would be a waste of a couple bucks to put one in your kit. If they teach you how to use, you know, an EpiPen, well, that would be a prescription item, but if they teach you how to use something else and you don't have one, buy one. I would certainly agree that as fire personnel, the 20-man GSA kits are basically a glorified boo-boo kit. They're nice for a lot of things, but they're not really designed for dealing with major injuries. We've replaced, at the Forest Service, we replaced all of our 20-man kits with more of an EMT level kit. But much of what's in there is not something that a layperson would necessarily be trained to use. So I think to a large extent that's going to have to be based on the level of experience and training your people have, and then make sure that they have whatever supplies they need to be able to do what they're capable of. And I know that's kind of a non-answer to the question, but
okay, well, I want to thank you very much today, Eric, and for sharing your expertise with us. And just before we go, I'd like to mention a couple of upcoming events we have. There will be another webinar coming up on prescribed burn associations in December. And then there will also be a Juniper workshop at the SRM annual meeting in Orlando in February. If you want to stay up with what we're doing and webinars that are coming along, please sign up for our newsletter on the website. And thank you very much for
Thank you
attending
all for your
today.
time and attention.